Thank you. Be part of this interesting IC, and I would be talking about what are the new innovations and what is the relevance, what are old ones and are still relevant. So primarily, I think the challenge in pediatric cataract is multiple compared to adult cataracts. One of the most common thing is as right now we were discussing about traumatic cataract, that you don't know how to calculate the IOL power, what is right, what is the target. So that is one of the challenges that is there since years altogether. And then the second challenge is visual access opacification, calculating which kind of intraocular lens to put. And now there are custom IOL sizings available. 10 of Vicryl suturing has been done, and we have been doing it, but it got published few years back by Dr. Jyoti. Post-operative requirements and what are the advances in general anesthesia which may be important when you take up a pediatric patient for cataract surgery. So refraction, which formula to use, how much undercorrection, how to undercorrect, and nowadays we have started using low concentration atropine also. If there is a myopic shift, you can use low concentration atropine. Posterior capsular opacification is almost 100% in 2 years. Within 2 years, if the age of patient is less than 18 years of age. The wonderful article by Michael Steger. And so you have to go ahead and do a, when you have the chance, you should do a primary posterior capsular access. You can do it before putting the IOL, or you can do it after putting the IOL. Here we are, this is how I was taught. So we first implant the IOL, because we were taught that putting IOL is more important than any other step in pediatric cataract. If there is a chance, you should put IOL in the bag. So in the bag IOL placement is the primary aim of the cataract surgeon, and then followed by that you can do a primary posterior capsular access. There are few advantages of that. It makes it little technically difficult because you have to go underneath the IOL and then do a manual capsular access. You can do it with a retractor once the IOL is in place. And this is the first video showing after putting the after we have put the IOL, and this is you see the ease of doing a posterior capsular access. It is much easier when you do it before putting the IOL, but then putting IOL in the bag sometimes may be tricky. So either ways is fine. Whatever way is you are comfortable with, you can go ahead and do primary posterior capsular access. Here we have done it before putting an IOL. So we will be putting a single piece PMMA lens in this particular patient. So once you do the access, you have to make a posterior capsular access, which obviously when you do it before putting the IOL, you will be doing it slightly smaller, because you are little worried whether you will be able to put IOL in the bag properly or not. So this was before we could implant the IOL. We did the posterior capsular access. And then primary posterior optic capture was, I think, described way back around 2 decades back, but it still holds good, and there have been multiple articles before, and there has been good body of work done by Dr. Abhay Vasavada and his team. They have published multiple articles even in younger children less than 2 years of age, where you can do a primary posterior capsular access and a posterior optic capture. And this is just to show a couple of cases. So this is where we put the IOL, we do the posterior capsular access, and then we try to nudge the optic behind the, so IOL is in the bag, and then we are trying to nudge the optic. This is, we are doing primary posterior capsular access still, and yeah, I can fast forward that. Yeah. Now we are inflating the anterior chamber, and then we will try to nudge the optic behind the, we are doing the vitrectomy. Yeah. So we can maybe out of vitrectomy. Okay, no. So we are just trying to put it, we are trying to put it under the posterior capsule. We can do it with a Sinski. It was a little easy, so I could do it with a retractor. And there's another small clip about, yeah, yeah. We are trying to push. You can see at the edge of the haptic optic junction, you can see the discontinuation of posterior capsular axis, and that is what tells you that it is behind the posterior capsule. And if if you get a if you do the surgery and if you get posterior capsular opacification, you can always take the patient for surgical capsulotomy, and that is what we are trying to show. This is a old patient, and you have to first remove any attachments between the capsule and the anterior part of the IOL, and then you have to go underneath. Yeah, so we are just trying to open up the posterior capsular axis which was already there, and then we go underneath the lens once again, try to eat away everything with the retractor. So it is almost like a vitreous axis. We keep the vacuum slightly low and keep the cut rate at a higher cut rate, slowly trying to, very similar to what we do in vitreous axis. Yeah, gradually opened up the entire posterior capsule. So IOL power calculation, we have the Inyadi's rule. Depending on the age, how do you calculate? You subtract the age from 7 and then do the undercorrection. This has undergone multiple modifications with people not just depending on age, but also saying that axial length is also another independent factor. Whether the cataract is unilateral or bilateral, IOL is a must in unilateral cataract, but you cannot undercorrect more than +3 or +4 diopters, even if the age is very young, because the child may actually develop an isometropia instead of improving. So how to undercorrect? Sometimes, I remember years back, we used to undercorrect directly from the power. That should not be done. You have to put up the amount of undercorrection in the machine to see the expected error of refraction and then undercorrect accordingly. You will be surprised that direct subtraction from the IOL power may be off by almost 1 to 1.5 diopters. And then we have been using atropine for patients who are above 4 or 5 years of age and are still progressing, like they have a very high myopic shift. And me and Aditya, we have done work on atropine 0.01% and 0.05%, where we found that atropine does slow down this particular myopic shift. Bag in the lens was very popular when it came as an idea. It was wonderful. The idea was that both anterior and posterior capsule should be put in a small sulcus which was there in as the edge of the lens. The problem is that right now I don't think it is available in our country, but technically it is difficult because you have to size up the anterior capsule and posterior capsule. They have small haptics also which do stabilize the lens till the fibrosis sets in. So I have not really used it. I think Ramesh has used it in some of the cases, but technically slightly difficult, looks difficult. And then we have been using customized lenses for small corneas. So this was one of the patients with very small cornea, horizontal diameter of only 9 millimeters, and the child was aphakic. Vertical diameter was 8.25 millimeters, and we could actually implant a slightly. Yeah, so this was made for OPL. So we could actually implant a slightly smaller lens. Power is 38. Total optic diameter is 4.5 and haptic is only 10.5. So we could make a small sized IOL and we could implant it in the sulcus. After doing the vitrectomy, we could implant in the sulcus. So you can now customize the lenses in microcorneas and small corneas, where we earlier used to tell the patient that we won't be able to help them by putting a lens. We can still do something for them. And general anesthesia has become, and I think much of the success of pediatric ophthalmologists or pediatric cataract surgeon goes to general anesthesia, because now you can pick up very young children. Post-operative nausea, vomiting has gone down. You can get a good feel. You can reduce the IOP through good ventilation. Hyperventilation is possible. Newer drugs like sevoflurane or laryngeal mask anesthesia can give quick recovery and deeper plane of anesthesia. So the future is important. Pediatric cataract we can now do at a very young age also. Under correction can be based on age, axial length. You can use atropine if myopic shift has occurred, and you can use any technique, but we do suggest that you should close the ports till 10 years of age at least. Thank you so much.
Thank you so much, sir, for that very comprehensive overview. Just a quick question about the latest innovations. I know, sir, you have an intraoperative OCT. Does that make a difference with how you deal with your pediatric cataract surgeries? Because that is an innovation that most of us would love in our own microscope.
I think it's very good for teaching. I can think of a handful of cases where it becomes essential to be able to do the case successfully, often in trauma cases where the lens is attached to the cornea. But I think that's an innovation. I think anesthesia actually is the most important thing. So there are a couple of things. In fact, isoflurane is better for children under the age of 4 than sevoflurane. And the reason is that isoflurane suppresses sympathetic activity. And the problem in children is that the choroid expands very quickly when their blood pressure goes up. And so you want isoflurane. And I don't do intraocular surgery in children with a laryngeal mask. I insist on paralysis. And the reason for that is that you want the end-tidal CO2 to be around 30 if it's safe for that patient. But yeah, everything else I would totally agree with you. The only thing, and I haven't managed to prove this yet, is ever since I started to do lens capsule polishing so that I don't get a white fibrotic anterior capsule, my rates of myopic shift have dropped.
Oh.
And the only way I can explain it is that when you have a white anterior capsule, the amount of contrast in the periphery drops. And we know from our myopia work now that it's your peripheral retina, when it goes into reduced contrast, drives axial myopia. But I don't know if I could work with the people here in India and to compare your numbers where the capsules are white, and the opening is small, and see if that's where the myopic shifts happen more. I can't prove it. I just have an anecdotal experience.
I have one more question. Dr. Savra is here. So I know you do flax. So have you tried doing flax in pediatric cases? I know only of Dr. Burkhardt, who has done a lot of cases.
Yeah, we have done flax, to be honest, mainly to try how things go. In practical life, it's not a practical option to consider, because you have to move the child under anesthesia twice. First to do the flax, then with the tubing back to the OR, do the thing, suture the wound, fill up, come back again. Sterility is an issue, and once you do the PCCC, it kind of contracts and drops back. So if you try and go and pick up the PCCC after a flax second, you'll actually end up disturbing the vitreous phase because it contracts and goes. So we have tried it, but I would not think it's a practical option.
And sir, what about capsule laser? That was something which is very exciting for pediatric cataract cases.
Yeah. So the capsulase looks very exciting, but again, I think it depends on your comfort level of handling the pediatric capsule. I would agree. I think that doing all the fancy lasers and capsulase and femtosecond, I'm not sure what it adds practically to the solution. The only time it's really helpful is when you've got an intumescent cataract, right? And you're worried about an Argentinian flag sign. Then it's wonderful. But other than that, and then they're a minority of the cases I deal with.
So my last question to you, sir, before we go to the next topic, is about the choice of IOLs. Like we have a lot of advanced monofocal IOLs, we have a lot of EDOF IOLs, we have toric IOLs. How do you decide which one you're going to use if you experiment from going beyond the spherical IOL we use?
So I'm not a very big fan of multifocals. So yes, I would go till maybe advanced monofocals, EDOFs, but not to multifocals. Torics is definitely a good option. Above 7 years, if you can mark up, and if you know that, you know, torics, I do use torics above 7 years of age, but I've never used multifocal because I don't know what it does to the contrast. There have been good articles where they say that you can use multifocals after 5 years of age, but I have never used multifocal before 15 years of age. So
Can there's a word of caution. I've been an expert witness for the prosecution in a law case where somebody put a toric lens in a 7-year-old girl, and it all looked very well. Then she became 16 and she wanted to wear contact lenses. Now she wears contact lenses. They correct her astigmatism. Now she has lenticular astigmatism from the toric lens.
yeah.
And she's suing the doctor for saying,
Why did
you don't, now because of what you did, I can't wear contact lenses.
I
So
think
be
you
careful.
can wear soft contact lenses. It's
Well,
only the
see that-
RGPs which will cause a difficulty if there's lenticular astigmatism.
So the problem is that she went for RGP because she has some corneal astigmatism,
Okay.
right? Because it's the corneal astigmatism that you're correcting with the
of
toric.
Of course.
And so be careful.
My curiosity is asking who won the case.
Huh? they settled out of court.
No, but the point here is very important. The point which the take-home message is that you should always talk with the patient. What you are doing, the patient should be informed. Patient in India normally would say that, you know, you are the best judge, but you can always write it down and tell the patient that this is what I am doing and this can happen. So when we implant premium lenses, we talk more.
So that's what I'm getting at, right?
Very true.
If we're going to use toric lenses in 7-year-olds, what are they going to understand? So I think that the advanced lenses should be used in teenagers,
Yes.
in whom there's an understanding of what you're
Very
doing.
true. Very true.
And people who put multifocals, the diffractive multifocals in children under the age of 8, they don't want to talk about what's happening to their contrast, sensitivity, and their amblyopia. Right?
No,
They never talk about that. But that's a real fact.
True.
So I think that's all I'm getting at, is the older the child, the better.
Better to just.
Absolutely.
Thank you so much.